Going to throw a little bit of a curveball this week in our muscle treatment breakdown and actually go through a very important nerve entrapment that occurs, specifically the accessory nerve. When it gets stuck in the trap, the levator, and even in the rhomboids, can cause a lot of issues. What's up, everybody? I'm Dr. Matt Maggio. I'm the creator of the Peak Method and the founder of Soft Tissue Revolution, where we show massage therapists how to make six figures, all while working less and not getting burnt out. No gimmicks, just results. So in this week's breakdown, what we're going to be going through today is actually what's called an accessory nerve entrapment. And it's a thing that causes a lot of problems, and a lot of people are missing that, specifically soft tissue therapists. So I want to break that down just a little bit more. So accessory nerve, what it is, it's one of the cranial nerves, and it comes out back behind the ear, and it makes its way down back through here, and then goes right down to about T2 or T3. Now, the accessory nerve is one of the few cranial nerves that actually leaves the skull and goes out and does things and controls things. It's a motor nerve as well for the SCM and for a little bit of the trap as well. But what happens is it gets really stuck and causes issues. So nerve entrapments in the body are really common. There's over 256 different places in the body where a nerve can get stuck. That's a lot of places. Now, when nerve entrapments happen, usually what the client presents with is like numbness, aching, burning, and tension. And especially in this area and through here where the trap and the levator come in. So a lot of times we think that it ends up being like an upper trap problem or a levator problem, but what happens is the nerve gets stuck. So think of the nerves. They're built with about 15% of extra slack to keep them healthy, like a rubber band. What happens over time, especially where it comes out and people spend so much time of their day in bad posture, looking down on their phones, working on computers, is that nerve gets pulled and yanked in different directions. When it gets pulled and yanked in different directions, the body actually creates a lot of friction. When that friction happens, it doesn't get enough blood flow, doesn't get enough oxygen, and the body starts to lay down scar tissue in there. And over time, that scar tissue gets bigger and bigger, and eventually it gets stuck to the nerve. And when nerves get stuck, the body really starts to panic a little bit and really tighten up. So the body engages in this thing called like protective tension. So when the nerve is really flared up or caught, it causes things to raise up. You got the clients that are like walking around like this, and you'll get in there and you'll do treatment on it. It hurts like hell when you're doing it. The client's like, yeah, that's it. But it never really seems to hold, and it keeps coming back. The problem is you're not addressing the nerve, you're actually getting into the muscle deeper, and that's not actually fixing it. So what I want to do first is show a video of an advanced palpation of that area so you can get a better idea of where that accessory nerve is. And then once we're done with that video and that palpation, it's one of the trainings from my system called the Peak Method. Once we're done with that video, then I'll go through some tidbits and some ideas to get in there and actually treat it effectively and get some long-lasting results. So the third test we had talked about was that cervical thoracic spine area flexion test where they drop their head down through there. So there's a couple things that can really limit that. One that everyone completely forgets about is actually an accessory nerve entrapment. Usually it comes out, it can get caught in here through the levator, it can get caught through anywhere in the erector group, the rhomboid, everywhere like that. So I like to get in there and palpate that, because if the nerve is getting stuck when patients go to move, everything tightens up and it protects. So if you can get the nerve right and find where it's getting caught, it can make big changes in that overall range of motion. So what I do first is I have the patient hold their arms just like that. What that does is it allows that shoulder blade to get out of the way. Then we get in there and drop the head down. So I'm gonna have you come up a little bit more and really get in here. So essentially, we look for our landmarks here. So we find the superior angle of the shoulder and go through here. Where that nerve lives is in through here. So I get in here and I do compressive palpation, really trying to feel where that nerve is jammed up. And it's gonna kick right out when it is jammed up with that scar tissue. The patient would even jump just like she did. Now, the thing is, it gets stuck right in through there. And that's where that scar tissue is. And the thing about the nerve is it's very superficial. It doesn't need a lot of compression, and too many people are way too compressive with it, and it causes problems. The next thing you have to account for is the curve in the thoracic spine. So if you just go straight in, you're going to crush it. You almost want to come in at a 45-degree angle as you get in there and palpate, and that'll really open that up. All right, so I hope you enjoyed that palpation video. Now I want to talk about the nerve itself. So the nerve is really, really superficial. And when you go through and find it, it's there, and you'll find that tension in there. Now, what I usually find is that a majority of therapists are way too compressive with it. They actually go in and crush it because the nerve is right on the surface. It should only need maybe like 8 to 10 ounces of force, but it needs it in the right direction, in the right vector. Another issue that you're going to run into in this area is the thoracic spine is curved in a little different way, so your vectors are a little bit different as well. A lot of times as people go too compressive and they go right in it, and they don't account for the vector of that as well, and they just compress on it. And just because it hurts doesn't mean it's actually doing anything. To actually break down scar tissue correctly, even in a nerve, you need proper depth, then tension to break it down. And what I find is that everyone's way too compressive in there, and it's really hard to actually treat that when the client is lying on their back or face down, because you're not actually able to generate enough tension. I like to treat these in the chair as well, but you also have to accommodate for the curve of the spine as well, because it's a little weird and the ribs throw that off a little bit there. So if you're having these clients where they always come in and they complain about upper trap tightness, it's always sore, you're getting in there and treating it, but it keeps coming back, it's probably because you haven't addressed the nerve correctly. And the first step is finding it. So rewatch that palpation video over and over again, and then once you find it, do your best to get depth and tension on it. I recommend, like I said, treating it with somebody sitting up in a chair. That allows everything to relax, and you can generate a lot more force and a lot more tension. So that's all I got for the video this week. If you like what you saw and you want to learn more about our revolutionary treatment method called the PEAK method, send us a message. We're always here to help, and we're always taking on new people that want to learn more about these new advanced soft tissue treatments. I really enjoy making these videos. The best thing you can do is give us a comment, a like, or share. Or if you have anything specifically that you want us to cover, muscle-wise, send me a message. Always here to help. I appreciate you guys, and I'll see you on the next one. Bye.